I'll start from the beginning. As most of you know, my name is Cheryl Shigla. I'm an outreach coordinator at Cancer Support Community Central New Jersey. And on behalf of Cancer Support Community Central New Jersey and Robert Wood Johnson University Hospital Somerset, we're happy to welcome you to the third and final session of Cancer Awareness and Health Disparities in the LGBTQ+ community, sponsored by the Far Hills Race Meeting Association and Robert Wood Johnson University Hospital Somerset Community Health Partnership. During today's Oncology Care and LGBTQ+ community session, we'll be discussing the cancers that the LGBTQ+ community has an increased risk for and how to reduce one's cancer risk and the importance of cancer screenings. Our presenters today are Dr. Kathleen Toomey, who is the Medical Director of Steeplechase Cancer Center at Robert Wood Johnson University Hospital Somerset, and then Paula Gutierrez, also the Director of Diversity and Inclusion at Robert Wood Johnson University Hospital Somerset. Thank you again for joining us today, and I apologize for any delay. Before Dr. Toomey speaks, I'm gonna go ahead and start our pre-presentation poll. Let's see if it'll pop up. Caitlin, so you might be able to do it since you're sharing your screen.
How would you like me to do that?
Do you have the poll option at the bottom?
I do not, it's just the PowerPoint presentation.
Okay, can you unshare your screen for a second? Okay, let me see. It's saying I'm active on a different, hold on one second. Kyle, are you using the Cancer Support Community outreach account? I don't know if you have the ability to do it.
I am.
Okay, can you hit poll and just start the first one if you can?
I don't have that ability.
Okay, I don't know what's going on. So we can just, if that's okay, Caitlin, you can just start on your end. Share the screen again, and then Dr. Toomey, we can just begin. Okay. I'm going to unmute you, Dr. Toomey, just so we can. Are you able to unmute on your end?
We're unmuted?
Yep.
Okay.
I hear you now, so you're good.
Okay, good. All right, so welcome everyone to my laundry room. We have, I don't know if it's good when it's going to start snowing, but we'll see. I'm home doing telemedicine during COVID, and so this is where I am today. Welcome everyone. We're going to talk about increased cancer risk in the LGBTQ+ population. And these are some of the cancers we're going to talk about. Anal cancer, which gives a 20 to 40 times higher risk. Cervical cancer. You've already heard about breast cancer. We'll talk a little bit about ovarian and endometrial, colorectal, lung cancer, and prostate cancer. And I think I can advance the slide. So, and I think Paula is going to talk more about this later on, but there are general risk factors that we have to be aware of. And if I talk to any of my patients, the one thing I say is that tobacco is the most important thing to do to stop smoking, which hundreds of times more important than anything else anybody does is to stop smoking. And we'll talk about ways to help if someone does smoke. Second general risk factor is alcohol, and the American Cancer Society and the American Institute for Cancer Research both say no more than 1 drink for women per day and 2 for men per day, no more than that. Obviously, less is better, but no more than that. The third general risk factor has to do with high-fat diets and weight. and it gives an increased risk. So that's something we talk about all the time. We all know what a good diet is. It's not so easy to do it all the time when we have so many things in front of us that are too easy to do. So we have to work a little bit at that. All of these factors are actually increased in the LGBTQ plus population. So those are important things to know about. And then we talk about HIV. And HIV causes an increased risk of anal cancer and cervical cancer, and those are the ones we normally think about, but also non-small cell lung cancer, aggressive non-Hodgkin's lymphoma, Hodgkin's lymphoma, Kaposi sarcoma. And I was around at the beginning of HIV, and I saw a lot of patients with Kaposi sarcoma and other cancers. And I keep saying that COVID reminds me of the beginning of HIV, when we didn't know anything and we didn't know what we should be doing. And thank God we've found lots of good medications for HIV, and it's become a chronic infection. And thank God we found a vaccine for COVID. So thank God for science, basically. And the next thing is something that's been up and coming for some time now. It's human papillomavirus infection, especially HPV-16. And I actually just had a meeting with one of my patients today, and we talked about getting her 11-year-old daughter vaccinated this year or next. And that would be important in helping us prevent these kinds of cancers. So maybe next one. So what are the barriers to screening? Why are people not getting screened? Well, the first thing is that in the LGBTQ plus population, we don't know very much. We don't have research and we don't have knowledge, and that's on us. I will tell you, a lot of the literature I read is a nursing literature. So the nurses have done a wonderful job in trying to look at this population and learn, but we need a lot more research and we need a lot more knowledge. And I will tell you, telling my colleagues that I was going to be giving this talk today, they were so interested and so wanted to know because they really, we as doctors want to help people. That's why we do this, and they really want to know what it is they don't know, because we do not have in our training until recently, and thank God for the Proud Center, that we're all starting to look at this. So the next barrier is, I'm calling it don't ask, don't tell. We've heard that elsewhere. So we don't ask, and patients don't tell us. And we need to make sure we have an atmosphere in which we do ask, and patients do tell us. And I will tell you, I'm very interested in having my patients teach me. When I see someone from a different culture, I ask them about their culture, and usually people are very happy to share about their culture. There is also a lack of insurance in this population, lower income, and then there are work issues related to gender. And then in general, there's been a poor experience with healthcare, and once again, having the Proud Center puts the emphasis where it needs to be. We'll go to the next one. So a cancer that we don't see very often is an anal cancer. So it's a rare cancer to begin with, but it is increased in this population, and these are some of the risk factors: receptive anal intercourse, multiple sex partners, anal warts, and those are the two viruses, strains of HPV, 6 and 11. So there are hundreds of strains of HPV, but specifically those two are involved with anal warts. HIV positive, so a very rare cancer, 2 in 100,000 in the general population. In the LGBTQ population, it's up to 40 per 100,000 in those who are HIV negative. and double that in those who are HIV positive. And I will tell you, I have seen this cancer. I've seen this cancer in the general population. And once again, you know, we're talking about viruses here. HIV is a virus and HPV is a virus. So these are virus-caused cancers. And, you know, the main symptoms that people might have, they may have some rectal bleeding, they may have a lump, they may have irritation. So it's important to have a gastroenterologist, somebody that can take a look and see what might be going on when people have symptoms. So basically, we have to feel comfortable in order to get to our doctors. So that not feeling comfortable is a barrier to care. We can go to the next one. So the question comes up about someone at high risk, whether or not to have anal screening. So we looked at the HIV Medicine Association, and they suggest an annual pap smear, just like we do for cervical cancer. You can check the cells in the anal area, and the anal area is the end of the bowel. But the problem with this is that it's not very common, so it may not be covered by insurance. And certainly, I think, may not be a common procedure that's done in general. Then there's the digital anal rectal exam where the doctor, we put our finger in the rectum and check the outside and feel for any masses. And then there's a scope. Anoscopy is a scope, which is just like a colonoscopy, but really looking at the anal area. And once again, our gastroenterologists are trained in doing that. And it's probable that having HPV vaccination at a young age is important. Virtually everyone who is sexually active will get HPV. Our immune systems are very good at keeping it under control when we're young. The cancers that we see may be, like cervical cancer, may be relatively slow growing. So we will talk a little bit about how we screen for cervical cancer. So I would say anal screening is not across the board, but if we realize someone may be at an increased risk, and especially if someone has symptoms, then we'll be much more likely to look and see what's going on. So cervical cancer is a kind of cancer that before we had the advent of the pap smear, and that was driven by patients and the American Cancer Society, not by medical people, but you know, women were dying of cervical cancer. In this country, we're lucky, we have lots of screening. In other countries, it's not so. The resource poor countries, we really don't do a lot of screening. So in those countries, you can see young women dying of cervical cancer, and it's not an easy cancer to die with. It's a locally invasive cancer and a lot of pain, and so prevention would be the best thing. That would be the vaccination for the young people, and the second thing would be screening. So we have to remember once again that smoking, as well as HPV and HIV, are risk factors for cervical cancer. And the guidelines are actually age dependent. So in the younger age, in the 21 to 29, it's a pap smear every 3 years. In the 30 to 65, it can be a pap smear every 3 years, or a pap smear and HPV testing every 5 years. Above age 65, if pap smears have been negative, then women or those with a cervix do not need to do further testing. We do the gynecologists will do pelvic exams, and they're looking for other things. But as far as screening that can reduce mortality from cancer, it is the pap smear and the HPV testing that are most important. We can go to the next one. So we wanted to talk about ovarian and endometrial cancer. And one of the biggest risk factors is obesity and a high-fat diet, especially for endometrial cancer. Alcohol and tobacco also play a role. For ovarian cancer, I always think about nuns because they don't have children, so they're at increased risk for ovarian cancer. And the problem with ovarian cancer is that there's no good screening. So even if you do blood tests or you do vaginal ultrasounds or all screening modalities, nothing has been shown to be a good screening test for ovarian cancer. So even pelvic exams, the ovaries are quite small and they're deep in the pelvis, and you don't really feel them until they're quite large. So it's watching for any signs and symptoms of bloating in the abdomen, pain, unusual pains. But once again, quite often ovarian cancer is found quite late, usually in stage 3 or 4. Endometrial cancer, on the other hand, can be found quite early, and the early sign is a postmenopausal woman who's having vaginal bleeding. So that's a fairly simple thing. And one of the problems, as I said, about screening is if we're not in the medical system and we don't have somebody to go to when we develop a sign or symptom of a disease, often it takes longer before we're able to find somebody we can trust and or see to get the testing done to make the diagnosis and to get the correct treatment. We do have GYN oncology at the Steeplechase Cancer Center, so specialized surgeons who specialize in the surgery for ovarian and endometrial cancer. We also treat patients with radiation therapy and chemotherapy as needed. We like it when people don't need to have treatment. We like it when we find things as early as possible. Let's go to the next one. Then colorectal cancer. So there's actually only one screening that prevents cancer, and that's for colon cancer. And the way it prevents cancer is having routine colonoscopy at age 50, and actually the age is going down to 45, every 10 years until someone doesn't have a life expectancy of 5 to 10 years. But a colonoscopy every 10 years, unless a polyp is found. If a polyp is found, then repeat colonoscopies would be more often. But what happens is by taking out the polyp, you prevent its progression from a benign lesion to a malignant lesion. There are some other methods of doing screening for colon cancer. And once again, the risk factors include obesity and diet. So the lack of a high fiber diet, the kinds of foods that we typically eat in a Western diet. The good news is that we're seeing fewer and fewer colon cancers than we had before because of colonoscopy. So the more people who get colonoscopy, the lower the rate that we have of colon cancer. It's one of the cancers whose rate is going down along with lung cancer because people stop smoking. You can use DNA in the stool, but if the DNA in the stool comes positive, then you have to have a colonoscopy. And you can do a virtual colonoscopy, which is a CAT scan, a special CAT scan. But once again, if that finds something, then the diagnosis is made by colonoscopy, and you still have to go in for a colonoscopy. We'll go to the next one. So the next one is lung cancer, and once again, HIV does increase the risk of lung cancer. And while not all lung cancers come from smoking, there are patients who get lung cancer who never smoked. The higher, the longer and the more cigarettes you've smoked in your life, literally in the lungs, in the bank, the higher the risk. So we do have low dose CAT scans once a year. It's a CAT scan which is done without any IV dye, and it's for people ages 55 to 77, and they're less than 15 years from having quit and have at least 30 pack years. So how we do pack years is if I smoke from 20 to 60, I smoke for 40 years, 1 pack a day, that's 40 pack years. So at least 30 pack years. If I smoke 2 packs a day for 20 years, that's 40 pack years. If I smoke 1 pack a day for 50 years, that's 50 pack years. So less than 15 years from having quit, between the ages of 55 and 77, and at least 30 pack years, patients should have low dose CAT scans once a year, and we have that available at the Steeplechase Cancer Center. And the most important thing, once again, is to stop smoking. And we do have a prevention institute that is free of charge through the Cancer Center and RWJUH Health, where they do an 8-week program once a week. It's done by telemedicine these days, and I think it lends itself to telemedicine. You can be at home and have a one-on-one. You can do groups, and this program also offers free of charge nicotine replacement systems, whether they're the gum or the inhalers or whatever they are. So that's available for patients or for anyone. And so I would highly recommend getting information on that. We'll go to the next one. And the last cancer we're talking about is prostate cancer. So for trans women, screening the body parts that you have, there are screening guidelines for prostate cancer, and mostly they have to do with getting a PSA, a prostate-specific antigen. That's a blood test. And what age and how often is actually an informed decision-making. It depends on the age of a person. It depends on their life expectancy. It depends on symptoms. But the risk factors there are older age. African Americans tend to have it earlier, and a family history of prostate cancer and other cancers, including breast and pancreatic. And then a high-fat diet and smoking increase the risk of prostate cancer. And once again, in the LGBTQ community, we have increased rates of these things, and I think Paula will go over that a little bit more. So we'll go to my last slide. So some of the resources that I give to my patients are from the American Cancer Society, something called the American Society of Clinical Oncology and cancer.net, and the National Comprehensive Cancer Network, or nccn.org, all have guidelines for cancer screening and information. I availed myself of the National LGBT Cancer Network, and once again, the Robert Wood Johnson Barnabas Health Institute for Prevention and Recovery. The number is 1-833-795-QUIT. And once again, that's a free program of 8 weeks of counseling and nicotine replacement. So I think that's the last of my slides, and we'll go on to Paula next.
Great, thank you, Dr. Toomey. Caitlin, are you going to pull them up, or should I?
Can you see the PowerPoint now?
Yes, awesome. Thank you.
Thank you.
Before I get started, does anybody have any questions for Dr. Toomey? She went over some really wonderful information, and I'll touch on some of those points, but I want to make sure if folks have any questions for her before we sort of switch gears a little bit.
Yeah, you can also just drop your questions in the box, or you can unmute yourself and ask, the question directly, whatever works best. But I think we may have one. Nancy is asking, what screening should be done by anyone 50 age plus who continues to smoke?
So I think screening for many things. My main point of emphasis. And listen, it's not easy to stop smoking. We get it. It's a chemical dependence on the drug, which is nicotine. It's the smoke that causes the damage. So my emphasis in terms of screening is that stopping smoking is much more important than the screening. So I would say, so my emphasis with my patients is, how can I help you to stop? It's not, you shouldn't smoke. Everybody knows that. That's not news. It's, how can I help you to stop? And I will tell you, before you get to see an oncologist, talking about screening is fine. So once again, lung cancer screening for those who continue to smoke. And when we see people for lung cancer screening, trust me, we really emphasize the fact of how can we help you to stop. So I don't care if you take nicotine. I don't care if you take the drug. I really care that you don't get the smoke into your lungs. That's what I really care about.
Great. And then we have another question. I know you said most sexually active people will get HPV. What does the vaccine prevent? Any tips on how to get insurance to cover more uncommon screenings?
So so for the HPV, so we all get HPV when we become sexually active, virtually everyone. So so you can't prevent something that's already happened, right? But we can prevent that in adolescents and young adults. So I think mainly getting the information out there, and getting the information out that it doesn't matter if it's boys or girls, whatever the person's gender, everyone, okay? So we've emphasized it for young girls, but we have not emphasized it for the boys. And in other countries like Australia, where they do things a little bit more centrally, they virtually, wipe out these diseases, head and neck cancers and anal cancers and cervical cancers. So it's really about education for our parents, for young people. And the second question was again?
Sure. Any tips on how to get insurance to cover more uncommon screenings?
Well, I guess, the main thing is always patient advocacy. So, and that's all I can say. I mean, it's, so it's hard enough to get insurance companies to cover the things that are common. So getting something uncommon is harder, but advocacy works. So, the more we educate and advocate, I think those are the two important things we can keep doing.
Okay, I don't see any other questions in the chat. So Paula, if you want to continue. And again, if you guys think of anything, feel free to just drop it in the chat box and we'll address them at the end.
Great, thank you, Dr. Toomey and everyone else for joining us this afternoon. So my name is Paula Gutierrez. I'm the Director of Diversity and Inclusion, as well as the Babs Sipperstein Proud Center over at RWJUH Somerset. So this afternoon, I want to spend some time briefly providing an overview on how we can better understand the need to provide culturally competent care for the LGBTQ+ community, and a little bit on how we do that, not just at the Proud Center, but also throughout our entire healthcare system, really because the importance of this is tied into prevention and getting some of those preventative screenings that are necessary, but there's a lot of barriers to get to that. And you know, when we think about access to care and equitable care, you know, the community, the LGBTQ plus community may have access to it, but what happens is when they enter an environment, you know, is it safe and is it equitable? So we'll talk a little bit about that this afternoon. So next slide. You know, Dr. Toomey alluded to this a little bit already, and I know we have in the past, in the previous webinars that we've done over the last 3 weeks, but really there is a long history of stigma and discrimination within the LGBTQ plus community that has created structural barriers for this community to access care, whether it's providers that may judge the patient based on their sexual orientation, gender identity, et cetera. You know, that can be a big barrier for individuals to come in and get care. But also really, is the environment welcoming? You know, if you're walking into, say, a doctor's office, are the pictures on the walls or the materials that are available for literature, are they inclusive of the LGBTQ plus community, or are they very gender specific? And typically a common example that I use is labor and delivery or maternity, or if you're going to an OBGYN, is a lot of that geared towards a male and female couple. You know, so when you're seeing folks that don't represent you, you're less likely to go and seek care at that facility, because of course you may not feel that the folks there may understand you, and it won't be an inclusive environment for you and your family. And also really learning about the LGBTQ plus community. It is a journey, and you know, that's why we're having this series of sessions. So we're really thankful to CSCNJ and our community health team, as well as a lot of the other folks that have kind of come on board to really be able to share that message and learn a little bit more about the population. So a little bit about healthcare avoidance behavior. So as we said already, previous experience with the healthcare system. You know, if individuals have experience where, for example, you know, violence against sexual and gender minority patients within the medical setting, you know, unfortunately this, you know, was common many years ago, especially for a lot of individuals where previously, if you look at the data and sort of the history of, you know, especially with gender identity and gender dysphoria, that was seen as a psychiatric disorder, and it was listed as such in the DSM. So there's a lot of stigma that still is carried on because of that. That has changed, and it changed, I want to say, in the early 90s, but you know, there's a lot of stigma with that. And that being said, you know, institutional discriminations, sign-in sheets, not being able to have your preferred name and gender marker, which is something that as a healthcare system we've been able to do at RWJUH Health, is making sure that we add preferred name, preferred pronouns, and gender identity in addition to legal name and sex assigned at birth. So, you know, from the time that you are giving your patients the information for them to sign in, that's already going to set the tone for how the rest of their experience might be. So if you don't have that implemented, that may be a barrier for folks to not seek care in your particular healthcare facility. Fear of coming out to your provider. Dr. Toomey alluded to the importance of having open conversations of, you know, what your sexual orientation is, and it's not meant to be intrusive or that the provider is being nosy, but it is an important part of a well-rounded visit, and the provider getting really to know what your preference is, and you know, being able to be mindful of what healthcare issues may come with that. You know, a lot of it is really centered around patient safety and your healthcare, and that's really what our providers at Proud, for example, do, because they do ask these questions, and it is important for them to ask that, because that way they will be able to better care for that patient, especially when it comes to preventative care. If there are certain tests, certain diseases that an individual might be more likely to have because of that, you know, that's a very real thing. So those conversations need to be had, but they're only had if that setting has been fostered for that conversation to occur. So a lot of folks may be fearful of coming out to their provider because when they do share that information, they may feel like they're being judged. So it's important that the provider approaches those conversations with sensitivity and also a little bit of background, you know, to say these questions may be offensive, but I want to make sure that you're safe and that I'm caring for you as the entire individual. So it's important to have that open dialogue with your with your provider. Gendered healthcare and services, so GYN, so making sure that we are referring to services in a very inclusive way. So oftentimes, people may say women's health versus OBGYN, because OBGYN services may be necessary for individuals that may have been assigned female at birth, but are now trans male. So when we phrase them in the way of women's health, that may prevent an individual that's a trans male from accessing those very necessary services. Again, another point that Dr. Toomey made about cervical screenings. If a patient needs a pap smear and they still have a cervix or still have their ovaries, they're going to need those preventative GYN services. So if we're phrasing it as women's health, they may be less inclined to seek those services. Lack of access to competent care, we talked about that a little bit too. When your provider is culturally competent and understands what pronouns are, what preferred name is, gender identity versus sexual orientation. All of these elements are very important for individuals to understand when they're working with the LGBTQ+ community, especially the trans population. And of course, negative health outcomes that are associated with healthcare avoidance. So if you've gone to a provider and it just hasn't gone well, or you didn't get the care that you needed, you're less likely to go to the provider. Next slide. So we'll talk a little bit about some disparities within some segments of the population. For example, in the lesbian community, there is a 4-time increased risk of substance abuse, such as tobacco, alcohol, and other drug use. There is a 20% increase of obesity. Also, something very common that we don't talk about, which is why it's important for you to have that relationship with your provider, is intimate partner violence. There are higher rates of sexual violence in bisexual versus lesbian versus heterosexual women, so 61%, 44%, and 35% respectively. This is very common. At the Proud Center, we do have resources available if an individual is in a situation where there is intimate partner violence, but that's also very important to be discussed with your provider, because their safety, again, your safety is their concern. So being able to have that conversation for them to then give you the appropriate resources is very helpful. Mental health concerns, stigma, we sort of talked about this already. There are higher rates of suicide in persons who have not disclosed their sexual orientation, or if their gender identity does not align with their sex assigned at birth, again, because of not being able to be their true selves. So that, that is, that's very awful. So being able to go into a space where you can talk about that. At the Proud Center, for example, when, from the time that our staff answers the phone, we do ask them, what is your preferred name? What are your pronouns? And just asking those simple questions to the person on the other line really tells them, okay, this is a place that understands what I may be going through, and then sets the tone for how the rest of their visit is going to be. So one of the things that we aim to do is, when we are referring patients to other providers, is asking if they're familiar with that, and if they understand how to appropriately navigate some of these conversations, because that will automatically prevent someone from going to a provider. Increased rate of breast cancer, lower rate of cervical cancer screenings, again, from both male and female partners because of the topics that we just discussed, and theoretical increase of ovarian cancer. Next slide. So when it comes to the gay male population, youth are more likely to experience parental abuse, bullying at school, and an increased risk of homelessness. And this, does apply to the entire LGBTQ+ community as well. Right now, unfortunately, because of the COVID pandemic, we are seeing a high rate of homelessness and unemployment. So, with all of those changes within these social determinants of health, you'll see a decline in people getting necessary health care because they may not have insurance. If they have insurance through their employer and they become unemployed, they can't get those necessary screenings, and then that may impact their ability to pay their rent or their mortgage, so they become homeless. So there's a lot of cascading effects that unfortunately we are seeing, and it is a very real thing for a lot of our patients at Proud. Increased risk of HIV, especially among minorities. Again, those who are homeless or are sex workers and need to seek out sex work in order to, to really make ends meet. Increased rates of anal carcinoma, which Dr. Toomey alluded to as well, but also mental health concerns. A lot of mental health concerns within the LGBTQ plus community that, we need to make sure that we are also, giving them access to mental health care. Now, this is an area where at the Proud Center, we are looking to also expand our services. So we currently don't offer mental health, but we do plan on doing that for 2021, Q1 in 2021. We may be offering mental health on site at our facility. So it's important because this also does come with a risk of suicidal ideation, substance abuse, and intimate partner violence, as we've already discussed. Next slide. So in the transgender community, they too face even more healthcare disparities, from the lesbian and gay population. Substance abuse, 29% increase is reported in illicit drug use, such as marijuana, non-medical prescription drugs. There is a higher incidence of alcohol abuse, and also in minority populations, the Latinx community, Black and African American community. Also higher rates of HIV infections. So, there's a big need that we are trying to push towards education for PrEP, which is pre-exposure prophylaxis for those that are at increased risk for HIV, to start on PrEP if they don't have the virus. And really it's one pill a day that is almost 99% effective in preventing the virus. So we try to make sure that we educate our patients on PrEP and get them started if they're at increased risk for HIV. Trans women are nearly twice as likely to have HIV, and nearly 1 in 5 Black trans women have the virus. So again, there's a lot of work to be done. Since we're on the topic of HIV, actually at the Proud Center, we've just hired a new medical director who starts the first week of January, who is not only board certified in internal medicine, but infectious disease, and has a focus on caring for HIV plus patients. So we're excited that he's going to be coming on board to really be able to add another necessary layer of services that we haven't been able to provide. Next slide. So within the clinical context, what is appropriate to ask? And again, there is a lot of discomfort in asking some of these questions, but I think the discomfort, or what I have found is the discomfort, is in not understanding how to ask these questions, but also why these questions are being asked. So you should only be asking information that is appropriate, but things like sexual orientation and gender identity are absolutely appropriate because they are about safety. And it's important that when you are asking these questions, that you're asking them of all of your patients, not just your LGBTQ plus patients. Providing gender-specific care in a non-gender manner. We talked about women's health versus OBGYN, right? Fertility treatment. We are going to be getting EPIC in the next year within our healthcare system, and EPIC has this great feature called organ inventory. I don't love the name, I'll be very honest, but the organ inventory screen allows the provider the ability to ask patients, what organs they still have. If a trans male patient has had a hysterectomy, then we can indicate that. That way, the care that is delivered is very specific to that particular patient, not just the gender that they identify with, because there exists gaps within assuming that because a person is, trans female or trans male, that they may not have, one or another organ. For a lot of trans women, they still have a prostate and they need a prostate screening. So it's important for the providers to be able to capture that. Applying screening guidelines to persons who are gender nonconforming as well, as we've already discussed. Next slide. So asking about behaviors rather than making assumptions, of course, another big piece. Just because someone's sexual orientation or gender identity are what they indicate doesn't give the provider the ability to make an assumption. You have to really ask, and is the individual at a higher risk or a lower risk based on their behavior? And of course, asking those questions in a comfortable and reassuring manner. Next question. Okay. So we talked about how we at RWJUH Health are creating an affirming and inclusive environment for the LGBTQ plus community. Our staff undergoes LGBTQ education upon hire, and this is for our entire healthcare system. Here at Somerset, we do offer this to employees as well, of course, because we have our Proud Center, but 88% of all of our healthcare system employees went through LGBTQ plus training back in 2017 before we opened the Proud Center. Verbal and written language, so making sure that our policies are aligned with being inclusive, access to gender neutral bathrooms, as well as having resources. We talked about resources and what type of materials we have within our waiting areas, making sure that they are not cisgender or heteronormative, but that they are inclusive for the diverse families that we are beginning to see. And also making sure that we have providers and the services that we provide are inclusive. Next slide.
So the next slide is the poll questions, but we still can't do that.
Great.
So we're going to skip to this slide and any questions now.
I don't have anything in the chat as far as I know. Just going to look one more time.
I have a question. This is Dominique. Can I just say my question?
Yeah, go for it, Dominique.
So my question is, how do you handle people who feel as if in order to be an LGBT or a culturally competent healthcare provider for the LGBTQ community, that somehow means that LGBTQ patients have an obligation to teach their providers? Where's the line that you draw? Because like, to me, I think that providers should, they should start off by actually learning stuff on their own because there's like more than enough information out there. But where's like the line between, you know, like expecting too much out of your patients, if that makes sense?
So, you know, when I said I ask your patients, I think that's actually part of the process, right? It's not that the patients have a duty to teach, it's that we have a duty to inquire, and inquire in a way that allows for discussion that's two-way, right? So I think the main point is that the discussion needs to be two-way. So if I don't ask, then somebody may not tell me, and trust me, all these years, quite often, people were not talking about this. But if we do ask, and once again, changing our forms and changing the way we approach everyone, I think is very important. But I will tell you that the medical community needs education, and we all need it, and we want it. And the Proud Center is, you know, one way of getting the education out there through grand rounds and just consultations and referrals. So I'm just saying it's a two-way street. So it's not an onus on anyone. I think most times, if we can have a good conversation, any patient would welcome that.
I never thought about it like
this
that.
This is Paula. If I may just jump in and add to your response, which I think it was very spot on. You know, I think it's important for everybody to remember that this is not a one size fits all. You know, just because, you know, because a patient identifies as LGBTQ doesn't mean that the care is cookie cutter, and it's the same for each person. It's very individualized. And when I say that, you know, it's going to vary from person to person. So, you know, it's really the patient does have an ownership of their journey as well. So, you know, when our providers are working with our patients, we always ask, you know, if there's something that isn't being covered or they're not addressing, simply because maybe they don't, they may not have had a patient that's been going through the same thing, or, you know, just because everybody feels very, very differently. And this is especially a little bit more common with our trans population. Not everybody transitions the same way. Not everyone transitions at the same time and the same timeline. So I think it's helpful when the patient is honest about where they are in that journey to be able to have the provider provide better care. And the other piece of that is that, yes, you know, for when a provider says that they are LGBTQ inclusive and and supportive, there is a level of responsibility for that provider or office to have had training. I mean, for us, all of our staff has had training, whether it's through Fenway or, you know, a litany of other resources that we offer through Cal and Lord, Mazzoni, a lot of the big names out there. But, you know, they have a passion for this work. So they do a lot of research on their own time. And a lot of our staff is also identifies as a member of the community. So there's a lot of layers to that, but I think that it certainly is a two-way street where the patient does have to also be very honest about where they're at and what their needs are, so that the provider can best support them.
Thanks. I never thought about it like that before, about it being a two-way street, but that's very true though.
Yeah, all of medicine is a two-way street.
Great. We don't have any more questions in the chat. Unfortunately, our poll feature is also not working today. So what I'll do is actually send out a Google form link, just a few questions asking regarding today's presentation. So I'll send it to everyone that has joined today. And if you have any other questions, feel free to email me directly. I am recording this meeting, so once we have all the sessions approved, I will send the links to all 3 recordings to everyone that registered. And that's it.